Good day. I'm Dr.K Gireesh, physician, neurophysician, and neurosurgeon. This is the RNA series number 53. RNA is nothing but random questions in neurology and neurosurgery with answers by Dr. K Gireesh, and that's myself. This is to benefit the practitioners of neuroscience and the medical field for a lifelong learning and also for public awareness. In this series, the question that I'm addressing is, what are the features of locked-in syndrome? LIS. By definition, the locked-in syndrome is a neurological condition in which the consciousness is fully preserved. Cognitive function is intact, but there is complete paralysis of the voluntary muscles of the quadriplegia and anarthria. Both upper and lower limbs are paralyzed. The patient is awake, aware, but unable to speak. Communication is usually by eye movements, that too vertical eye movements. The horizontal eye movement will not be there. The neuroanatomical basis of this, the key lesion is in the ventral pons. The pathways affected are the corticospinal tracts, producing the quadriplegia, corticobulbar tracts, loss of speech, and the facial movement. And reticular activating system, ascending reticular activating system, the consciousness is preserved. Vertical pathway that are spared actually, the vertical eye movement. Horizontal will not be there. So that in fact is the features. And causes, it can be vascular, a basilar artery thrombosis, or a pontine infarction or hemorrhage. Other causes are trauma to the brainstem, demyelination, example multiple sclerosis, tumors of the brainstem, central pontine myelinolysis, osmotic demyelination, and infection is supposed to be very rare. The clinical features are motor, quadriplegia, paralysis of all the four limbs, loss of facial and the bulbar movements, anarthria. Eye movements, vertical eye movement is preserved, blinking is preserved, horizontal gaze is often lost. Sensory, usually intact, may be variable. Consciousness is fully alert and aware. Normal sleep-wake cycle is seen. There have been subtypes like a classic LIS, quadriplegia with anarthria, classic locked-in syndrome. Incomplete, some additional voluntary movements will be there. A total one, every eye movement is lost. Even eye movements are lost. And extremely difficult to diagnose. It resembles coma. Clinical suspicion is the key in diagnosis. Patient appears like coma-like but has preserved awareness. Investigations, MRI brain shows a pontine lesion. CT scan shows an early detection in stroke. And EEG, normal, helps differentiate from coma and vegetative states. The differential diagnosis from coma, there is no awareness, because loss of awareness of self and environment is coma actually. And vegetative state, wakefulness will be there without awareness. Minimally conscious state, partial awareness will be there. Severe Guillain-Barré syndrome is only a peripheral lesion and not a central. So the management will be according to the cause. Like if it is vascular, one can try thrombolysis, thrombectomy, correct electrolyte imbalances, especially if features of anticipated as central pontine myelinosis, especially rapid correction of hypernatremia can produce a central pontine myelinolysis. Supportive care, ventilative support if needed. Nutrition, especially either nasogastric or a PEG feeding has to be done in the long run. Preventing complications like deep vein thrombosis, infections, pressure sores. Rehabilitation, communication training, eye-coded systems. Assisted devices for eye tracking computers. Psychological support is essential. You can do eye blinking, S-no coding, alphabet boards, eye tracking technology, then brain-computer interface which is emerging. Prognosis depends upon the cause and extent of the lesion. Mortality is high in the acute phase, especially vascular. Some regain the limited movements. Many remain severely disabled but cognitively intact. Well, the eye is maybe the only window to a very fully conscious mind trapped in a paralyzed body. That's intact the features of locked in syndrome. Thank you.